This is Professor Ariel Ortiz Lagardere, streaming live from the International Bariatric Club Studios in San Diego, California. It is a great honor to announce that today is the 105th IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series was created during the beginning of the COVID-19 pandemic in March of 2020. And is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars is to provide a free and first-class surgical education globally to improve patient care. In addition, the 5th IBC University of Oxford World Congress is being held 17th through the 19th of 2024 at the University of Oxford in the United Kingdom. For more information, go to ibcclub.org. The theme of today's multi-streamed 105th IBC University of Oxford Hot Topics in Bariatric Surgery exclusive webinar is Dangerous Decision-Making in Giant Hiatal Hernia Repair Surgery, and will feature experts from Portugal, the United States, the United Kingdom, Chile, Germany, France, and Mexico. The IBC University of Oxford webinar partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, David Medical, Stryker, Medtronic, our gold sponsors, Ethicon Endosurgery, USGI Medical, XNY Medical, ConMed, Reach Surgical, Karl Storz, Blue Sail Surgical, sponsors Intuitive, Moon Surgical, Arthrex. The chairs of today's webinar are Dr. Yalini Vigneswaran from the United States and Professor Carlos Vaz from Portugal. Dr. Yalini is Advanced GI and Bariatric Surgeon, University of Chicago, Surgical Director of Education, Institute Director of Esophageal Diseases, and Program Director of the Advanced GI Surgery Fellowship, University of Chicago, and Medicine and Biological Sciences, Chicago, United States. Dr. Carlos Vaz is Director of the Bariatric and Metabolic Surgery Center and Head of Robotic Surgery Unit in Hospital CUF Infante Santo, Lisbon, Portugal. I will now ask Dr. Vigneswaran to introduce our esteemed moderators, Dr. Alexis Sanchez from the United States, Mr. John Loy from the United Kingdom, and Professor Juan Eduardo Contreras from Chile.
Thank you for that kind introduction and the pleasure of introducing our moderators. Dr. Alexis Sanchez serves as the Corporate Director of the Robotic Surgery Program in Orlando Health, Florida, and the USA. Mr. John Loy serves as a consultant upper GI and bariatric surgeon at Homerton University Hospital in London, United Kingdom. And Professor Juan Eduardo Contreras serves as the adjunct professor of surgery, bariatric and metabolic and gastrointestinal surgeon at Clínica Santa Maria in Santiago, Chile. I will turn it over to Dr. Vaz to introduce our first speaker.
Muted.
Okay, sorry. So it's a big honor and a big pleasure to be here. So I thank my good friend Harris and to all the IBC organization for the invitation. And it's even a big pleasure to introduce Professor Dieter Birk. First of all, he's a very good friend. In common, we have that we like the best wines of the world. But also, he is chairman of the Department of General Surgery at Klinikum Bethlehem Ludwigsburg in Germany. He's also a member of the board of directors of the German Society of General and Visceral Surgery, and is the chairman of the German Working Group for Bariatric and Metabolic Surgery. He will talk on the issue dangerous decision making in synchronous giant hiatal hernia repair and bariatric surgery. So thank you, Dirk, and the measure is yours.
Yeah, thank you, Carlos. I hope you can see my screen. If yes, then
we do.
can go ahead. Okay, well, not only the love for good red wine, but also for surgery is a common goal of, I think, all of us. And it's an honor, of course, to be another member in this prestigious series of talks. If I'm talking too long, just stop me. But I think the topic is so important that we really have to get down to it. And I'm sure at the end of this webinar, we'll have some insight. When I got this topic for my talk, I pulled out the newest textbook I have, and it is not as new as you would think. It's from 1957, but I found it just a couple weeks ago in an old bookstore, and I looked through it, and what I saw is that even in 1957, and that's just a few years after Nissen actually proposed to do something about this problem. But this is actually from Mr. Tanner. He was a surgeon from London, and he introduced this type of reconstruction of the hiatus, and they even gave us in 1957 some results on how they did it. Actually, the only result you get at that time was you survive or you didn't. So we're a little better than this today. But let's define large or giant hiatal hernia in the beginning. I think we have a very good instrument to do that. And the group from Rudi Pointner from Austria gave us this instrument a couple of years ago. It's called hiatal surface. And the hiatal surface is something that will kind of be our uniform way of telling each other what type of hernia actually we're dealing with. Because the hiatal defect, I think, is the most important factor of the outcome of our reconstruction. So in the initial point of publication, the smaller hiatal defect would be hiatal size of less than about 4 square centimeters. And if it gets up to 5, 7, or 8, then it's something that we really should define as a large defect. Maybe some of you do that, maybe some of you don't, but that's pretty easy to do. And I will show you now. This is the chart that hangs in my OR. It gives the width of the defect and the length of the defect. You just measure those two measurements, and then you end up somewhere down here. When you end up in green, that's for me and my consultants, that's something, hiatal reconstruction, you should augment with something. Now, this is when we measure, little scale inside the reconstruction. You can see this already a redo surgery. So this would be a length of about 4 centimeters and a width probably about 3.5. And after that, you know what you need to do. So what are the options? If we have a patient that has a bariatric problem, but also a large hiatal hernia. Well, we could not do the hernia, but do a sleeve or another bariatric operation. We could do a bariatric operation, mainly a sleeve, but repair the hernia. Or we could be a hero and do both and be a guy like this. And we all want to be heroes, of course. But is it the safest way to do? Well, let's see how good are our results for repairing large hiatal hernias. I think this is a very good study that gives us a real-time picture of what's happening out there. It's from Australia. Some of you probably have read it. It's a 5-year follow-up of a randomized controlled trial for large hernias. And they did 3 arms. They did suture repair alone. They did a absorbable or non-resorbable mesh. And the results after 5 years were astonishing because they were terrible. And in all 3 groups, we had a recurrence rate of about 40% after suture repair, of about 57% after the absorbable mesh, and about 43% after the non-absorbable. So if you look at this, no matter what we do, we're going to fail in a bit less of 50% of those cases. So this is something that we have to keep in mind. So what else do we know? This is a study from Italy, from Christian Baru and a group from Gianfranco Sileccia. And what they did, they looked at all their bariatric patients and they decided whether, depending on the hiatal surface, whether they should augment with a resorbable implant. And the failure of hiatal reconstruction was only 8% in suture only, and when they reinforced, it was 4%. So that's really good in comparison to what we just saw. But As you can see, the hiatal surface was only about 3.4, so that's really small. That's not the giant hernia we're talking about. So solve both problems in one operation? If yes, augmentation of the hiatal closure using what? Permanent implant? I have my constraints about that. I will tell you later on. Bioabsorbable? Yes, my way to go. Biologic? Not anymore. Too expensive, in my opinion, doesn't work. And of course, we have to ask ourselves, should we exclude certain higher risk of bariatric operations if we do it both at the same time? So what would you do? 62-year-old female patient, BMI of 46, and this type of hernia. Seeks help for both problems. This is what I did. I only did the hiatal reconstruction. This is my general way of going. If you wonder why the instruments look funny, it's not a robotic operation. It's a traditional laparoscopic operation using a full articulating instrument and energy source, using or entering the correct plane, usually along the right pillar. That's my usual way of entrance. And this articulating instruments mimics a little bit the full robotic operation that you will see later on from Caitlin in her presentation. So I will just go on a little bit for the sake of time. This is now already, as if the dissection is done correctly, there shouldn't be a whole lot of bleeding at all in the mediastinal area, because if you stay in the correct plane, the bleeding will be minimized. If it starts bleeding, you usually know something is not the way it should be. And the advantage of the full articulating instruments, of course, is you can just kind of go under the esophagus. You can see the vagal nerve down here, pop up on the other side and put a tape around or something else and go on. And this is the reconstruction I usually do. The hiatal closure done with non-resorbable stitches. There's a reconstruction of the angle of his, and there's a bioabsorbable implant to augment my repair. American study from Matt Crow's group, 38 patients operated concomitantly. So that's the question of our talk here. Bypasses, sleeve resection. As you can see, a lot of those hernias were diagnosed intraoperatively. So in my opinion, they were not really that big, because usually you diagnose a big hernia during the preoperative endoscopies, which we know we should do in all cases. In the follow-up, PPI medication was reduced quite significantly, so that's a good result. So another one of my cases, a patient that had a sleeve and developed severe reflux, and also a quite large hiatal hernia. Again, about the same procedure. I use a robotic camera holder. That is why the picture is quite stable, so no moving around of the camera. Go through this real quick again about the same procedure as in the other patient. I do an anterior and a posterior closure. Usually I try to stay away from stitches just on one side, because then I think it's a little bit more like an obstacle for the esophagus to pass through. So I think this is the more anatomical reconstruction. And again, oops, that was a little bit too fast, but I think we can go on. So what about the long-term results of non-resorbable implants? And this is the one of them that I really don't like too much, because it has, as a permanent implant, the long-term complication risk of migration and obstruction. Maybe some of you might use this or have used it. The group here from Lobo and Priego, in their experience, have used this implant quite frequently in the beginning, but it dropped down quite significantly. And why was that? Their conclusion from this long-term result after the Curasoft mesh was, however, the rate of post-operative complications and mortality is excessive. The use of meshes in hiatus keeps on being controversial due to severe complications related to them. In their series, they had a mortality of 4%, which in my opinion is extremely high for hiatal reconstruction. I think most of you will agree on this. And this is an experience. This is a patient had a bypass with a fully migrated pouch into the mediastinum, and with a severe obstruction. This is what a Crura soft mesh looks like after 2 years. It's not soft at all. It's a huge chunk of foreign body that is contracted, impossible to move around, and trying to get into this mediastinum around this foreign body, which is extremely difficult to take out and also very dangerous, because if you try that, you will probably destroy the whole anatomical structure, not talking about nerves and large vessels. They're just around this area. So trying to get into the mediastinum around this foreign body is quite challenging, takes time, and as one talk later on, we'll focus on the use of energy source. At this point, you have to be careful. Now, I asked the anesthesiologist to pass down the NG tube, and he said, "No, it's stuck. I have to push harder." I said, "No, don't push, please, because the next thing you're going to see is the tip of the NG tube looking at you, and it is something you really don't want to, because you have the perforation up here, extremely difficult to take care." So go on, change from a high energy output to a low energy output, which means scissors alone. And then finally, I was able to dissect along the right pillar, which is kind of hidden behind this huge chunk of foreign body. So now, still trying to free the trapped part of the stomach that is inside the chest is the option, or the only solution to this problem of the patient. And now entering this cavity, fortunately, it was just a hernia sac, made this now possible, because this is where the pouch was stuck in the mediastinum. Now, finally, I was able to get it down. And I think at the end, closing the hiatus was just a stitch with the pouch now in the correct position was the only thing I could do for this patient. So what's the story behind this? Be careful with permanent implants, because that's something down the road that might cause serious problems to the patient. So my conclusions are: the outcome of the giant hiatal hernia repair is unsatisfactory as it is, and should only be burdened with a concomitant bariatric procedure in selected cases when the anatomy and the tissue quality does allow it. Two-stage approach, in my opinion, is the best approach. Do one problem first, and the primary operation is directed towards the main clinical problem. Augmentation of your reconstruction is recommended, in my opinion. However, without the permanent implant, stay with the bioresorbable. There are two very good products on the market. Concomitant closure of small symptomatic hiatal hernia is supported, of course, by the data in one approach. And that's the view from my OR. Outside, the weather is just as good now. This is the wine growing area. And here we are again with our common goal, saving or making the lives of our patients better, and at the end, drink a nice bottle of wine. Thank you very much.
Thank you. So thank you very much, Dieter. Great presentation on a difficult subject. I have a question for you. You said that in the giant hernia repair, you should use some augmentation device, and you said that there are some good stuff on the market. What do you normally use?
Well, I have two different products I use. The one is the Gore Bio 8, and the other one is the BD Phasix. And when do I use which? When I think the closure is under a strong tension, where I need strong, immediate mechanical strengthening of my augmentation, I would use the Phasix, because it has better initial mechanical strength. When I think reconstruction, augmentation by production of more scar tissue down the line is more the issue, then I use the Bio 8, because it has less mechanical strength, especially after about 2 to 4 weeks, but produces a lot more collagen down the road. So it's a little bit in between the two. there's no like strict decision, so I kind of it's more like a gut decision during the operation. But I have them both in the OR.
So you said BD Phasics, and what was the
The
other?
Gore BioA.
Okay.
So I'll
Thank you.
challenge you a little bit on that. So you presented the data that, Watson's group had on that, there's no difference if you use a absorbable or primary closure. So why do you still use absorbable mesh? Are you concerned about the short-term recurrence? One thing our group has developed, and not too much of a plug, but we developed a new technique where we actually harvest the posterior rectus sheath to augment the hiatus as a pedicled flap for these giant defects. And I've actually started doing them for these patients with high BMI, and I'll do that and then do a gastric bypass usually for those patients. But I know it's these cases obviously are very challenging, and we're always worried about having to go back. So why do you use the absorbable mesh? What are you trying to prevent? And then the second, what's that? One more question. Do you counsel your patients differently for these high BMI patients in terms of their recurrence rates? Because with these giant hiatal hernias, high BMI is obviously a risk factor for recurrence.
Okay. All right, so I start with the first question. Why do I use anything? Because the data out there tells us there's no difference. Well, I think that's only half of the story. I think there is a difference, and I think those patients where the hiatal closure is difficult or non-achievable, they need all the help they can get. So what is the best help we have? You've mentioned like a rectus muscle transplant. There's the ligamentum teres, a plasty. There are a few other things around. I personally, I try to stick with my concept of augmenting with a bioresorbable, and I counsel my patients towards exactly what you've mentioned. First of all, high BMI is by general leads to a higher recurrence rate. That's one. And number two is I usually tell them, this is your huge hernia is a little bit like an oncological problem. We probably will need 2 operations. And the first one will close your defect to a certain extent, and the risk of reoccurrence is going to be about 30% in my series of now do this more than 20 years. And the second operation will not be that much more difficult, actually. And usually the patients, after when they go home second or third day, say, well, this has not been bad at all. And when they come back, say, well, I know I have a recurrence, but you told me. And just do it again because it wasn't all that difficult for me as a patient. So this is my approach.
When you do that primary repair, do you do anything with the stomach if you're not doing a bariatric
Yeah,
procedure?
I do the reconstruction of the angular fist. So that's what I showed you. I don't do any kind of valve or anything like that because usually those patients don't have a reflux problem. They have a dysphagial problem usually.
Yeah. Dr. Contreras, I think, has a hand raised.
Thank you, Dr. Big. Can you hear me?
Yeah, I can.
Fantastic. Contreras from Chile. Nice presentation, nice talk. Congratulations. I have 2 questions. The first is do you agree that the first and less dangerous decision is to perform only a Nissen fundoplication in young higher hernia and forget the bariatric in this case? This is one. On the other is what type of suture or how to you fix the hiatus with the suture? Use not absorbable, is running suture or separate suture? Can you explain, please?
Okay. Well, second answer, I use a non-resorbable braided suture, an O suture, like an Mercilane O. and there are different options. I know other use a Z type of reconstruction, or they use the V-lock stitch, but I kind of do it like this for many, many years, and I kind of like it that way. Usually because when I go back, I immediately recognize my stitches when I do recurrent cases. And if somebody else did it, then it looks different. So this is why I stick to it. And the other question was, do I do a Nissen fundoplication in bariatric patients with a hiatal hernia? No, I don't, because that's not their problem. So their problem is directed towards their primary clinical problem. Is it obesity? And the hiatal hernia is not that important to them. They have no dysphagial problem. I will do the bariatric case first and then go back and do close the hiatus once they lose 50, 60 kilograms. And if I find it safe at that moment to do both, then I will do. But this is something, again, this is not evidence, this is eminence. It's a little bit like about the so-called gut feeling.
But also in patients with a very symptomatic GERD too?
Okay, so you were talking about the bariatric, the obese patient with a symptomatic GERD. Yeah, difficult one. So what do we do with that one?
In this case, use the bypass?
Yeah, well, that's an option. That's probably the one that solves it all. But as you've seen with the last patient in the video, also the bypass with a large hiatal hernia will cause problems because the pouch will just migrate into the chest, and that will, with a lot of those patients, be also a problem. But the bypass is a viable option if you have a symptomatic GERD and the bariatric patient. Absolutely.
Okay, thank you, Dr. Beck.
I have a last question. Just a last question.
Okay. So, Dr. Berg, congratulations for such a great and concise conference about this topic. Do you have any experience using DuraMesh? I mean, this new concept of mesh suture. In theory, it will lead to a better distribution of the force with in addition to the, body reaction to it without having too much mesh in contact with the esophagus and the stomach.
You're talking about this new type of suture that kind of expands.
Correct.
Yeah. I have it ordered, but I haven't used it. But I think I will use it, and I will see if they don't pull through the muscle as easily as another suture will do, and maybe that's also going to help us down the road. But no personal experience so far.
Yeah, I think it could be a great. I mean, nobody has too much experience using it, but I think it's going to be a great alternative.
Okay, thank you for your comments and questions.
Sure. So I will introduce our next speaker. It is an honor to present him. Dr. Lee Swastron is a prominent leader in the minimally invasive surgery field. He's Chief Innovations Officer and Scientific Director at ISU Strasbourg. He's Professor of Surgery in Oregon University, and he's an honorary fellow of the Royal College of Surgeons and the Brazilian College of Surgery. Thank you, Dr. Swastron. It's really a pleasure to have you with us today. Please go ahead.
Thank you, Alex. Certainly a pleasure to be invited again to these always interesting webinars. Really enjoyed Professor Burke's presentation, and it actually is a nice segue into my talk. I took the liberty of changing the title very shortly, slightly from the topic I was given, and change it to what can possibly go wrong with the use of laparoscopic energy in the mediastinum. And I think if you look at the title of this webinar, dangerous, plays a big role, and for sure you can get in big trouble working in the mediastinum with energy devices. So conflict of interest statements, this is the burden of being an innovations director. So, we're really, these esophageal hernias come in different sizes, as we heard earlier, but really, I think in our mind, we're really dealing with the ones that are massive like this. And essentially, the stomach is in the mediastinum. We often say it's in the chest, but technically it's in the mediastinum between the lungs, and can be quite cavernous and require advancing the trocar positions to gain access. But I think key to this discussion is it can involve lots of work up in a very tight space, which is the mediastinum. So certainly this leads to dangerous territory, if you will. You can look at this very crowded slice from a CAT scan and see numerous rather spooky structures immediately adjacent to the intrathoracic stomach. And I think we know kind of what most of those are. They include some rather massive blood vessels, of course, the vagus coursing through there as well, both lungs and of the heart anteriorly. So it is not a very friendly environment to be working in at all. And as you can see, you often have to really get into this space to do the work. Let's see, advancing a camera directly into the through the hiatus to do these very high, wide dissections of the sac. If you're lucky, there's not a lot of inflammation, and the sac can be done with a lot of blunt dissection, but often you do have to use energy sources to provide hemostasis and to complete the dissection, especially if you need to mobilize the esophagus to bring it down into the abdomen and try to avoid colus gastroplasty. And you can just see, even though this looks like a normal visual field, we're really operating in a cubic space that's probably 3 centimeters by 3 centimeters maximum. So the instruments are very close to each other, and you have to take a lot of care to avoid conflict of the instruments. And then we'll discuss some of the energy ramifications that all this has. Just above, you can see the pulmonary vein being carefully retracted out of the way, as well as the vagus, esophagus, and the vena cava down the left side of the image. So laparoscopic paraesophageal hernias are really a different animal than a common anti-reflux surgery. We know that anti-reflux surgery, laparoscopic anti-reflux surgery, is very safe. Mortality rate is exceedingly low, 0.1 or less, and major complications leading to catastrophic events are rather rare. That's different than a lap paraesophageal hernia, where most reports show a mortality rate between 1% and 3%. 3% admittedly being in the early days. This is a paper that we published with John Hunter many, many years ago with a 3% mortality rate. More recently, there was a NISQIP data from the United States published with thousands of paraesophageal hernias and showing a mortality rate of 1%. That's still quite high for a benign disease. So what are those complications? Of course, postoperative bleeding is one, but you'll see here in that NISQIP study listed cardiovascular injury, and although they did include some electroconductivity complications from that, still it was ranked quite high in the list of complications from paraesophageal hernia. And of course, all the other ones, perforation, dysphagia, recurrence, and even minor ones like bloating. So cardiovascular injury, obviously a normal anti-reflux surgery would be almost never encountered. And so that really is a new animal for these procedures. There's really a smorgasbord of injury options. Once again, esophagus, stomach, aorta, etc. There, I think a particular concern are these. Mediastinal perforation of the esophagus can be very deadly, as we all know. Stomach is not a good thing either. Injury to the aorta and pericardium. All these are potentially catastrophic, but in fact are fairly rare with injury. Why is that? Well, esophagus and stomach are quite muscular, rather thick organs. Aorta is fairly muscular and resistant to, let's say, small heat in injuries. Pericardium and heart is fairly tough as well. On the other hand, the venous structures in the mediastinum are very thin and very hard to control if an injury does happen. So the vertebral veins and pulmonary vessels really can lead to quite rapid on-the-OR table death, which I think we've all heard cases of, and hopefully nobody in the audience that's listening has ever had that happen, but it certainly does happen. So back to the topic, that all this leads up to the fact that the choice of an energy device is very important. Not so much all these devices we know work adequately, and we see people use them quite freely. Most of us have a personal preference for one over the other, but they wouldn't be on the market if they were blatantly unsafe. On the other hand, each of these has different characteristics as an energy source that have to be taken into consideration if you're going to use them. So the choice is very personal, and you're unlikely to be dissuaded by the scientific evidence, but nonetheless, you have to know the instrument and its limitations, and as well as its advantages. So I'm going to talk a little bit about the usual subject. It's not terribly exciting, about energy issues and safe use of electro energy and surgery. Drew a lot of this from the FUSE program that has been published by Sages and is a very good program. If people haven't heard of it, I recommend that you look it up. It's very easily to go through and very educational about safe use of energy. So surgical injuries are amazingly common. In fact, as you can see, many of them are missed and can lead to extensive postoperative problems and medical legal problems as well. And frequent, most surgeons have experienced it or had somebody in their hospital experience it. I think, in fact, monopolar probably is the most complicated when it comes to safe use of energy. And that's because it's an open circuit that involves the patient in the whole thing. And we have to be careful with the grounding, all these things that we've been taught about, and all the rules to adapt to the guidelines for this. So I think most people are aware of this. It's just that if you're going to use monopolar cautery, you have to keep in consideration grounding, the circuit, where you put the grounding pad, and all the other elements of risk that can happen with monopolar cautery, including inadvertent activation that can cause burns. These can be not seen quite easily, especially if you're working in a tight space like the mediastinum. And of course, direct thermal, when you have instruments that are millimeters away from each other and you use monopolar cautery, you run the risk of direct thermal extension. Here you can see an instrument elevating the pericardium out there and a hook cautery that's very close to it, and quite easily you can get a spark that jumps across the other instrument and can cause a burn. As I said, pericardium is fairly resistant. Other organs are, but if they were retracting, say, one of the vertebral veins or pushing the vena cava aside or the pulmonary vein, this can result in a catastrophic event. Also have to be careful about blood vessel bridging. Blood vessels that can be amazingly short in this narrow space because that can transmit monopolar energy as well. And I think we know a lot about this and have been taught about this from common laparoscopic cholecystectomy injuries. And one of the hallmarks there, although I think it's rare to use clips of the mediastinum, but in a crunch situation, if you do have some bleeding of the mediastinum and you end up putting clips in there and attempt to control it, that can compound the injury because electrocautery can be transmitted to those clips. And so you have to be careful about that factor as well. And of course, all the other issues about monopolar cautery, insulation failure, etc. You have to really be careful about your instrument maintenance and make sure that your instruments are carefully kept up. And of course, the infamous capacitative coupling, which is kind of a mysterious event of electron transmission, where you can get an injury out of sight from that as well. And I think we're all familiar with that phenomenon. I won't go into that anymore. So that leaves us with bipolar sealing and all of its cousins. Professor Burke was using the Olympus Thunderbeat device, which is a hybrid ultrasonic and bipolar device. And so these are all kind of generalizations, but bipolar is relatively safe, but not perfectly safe. You lose a lot of these adjacent contact transmissions, capacitative coupling, and issues like that. But it does get quite hot, as we all know, and has a lot of potential for adjacent tissue damage. And once again, if you're in a tight space, this can cause problems. So you do have to know about activation times, what sort of settings you're using, etc. So on to the third one, mechanical wave energy, which is often called ultrasonic. And we are very familiar about that. Most of the major companies now make a ultrasonic vessel sealer, if you will, sealer cutter. These vibrate very quickly, but don't transmit electricity between the jaws, and therefore, at least theoretically, are a bit safer. So it uses friction, it generates some heat, seals the vessels fairly effectively, and then the vessels, the coagulum falls apart and you have a division. At least theoretically, it has less thermal spread than bipolar. On the other hand, it has some other issues about it. One, I think you have to be more familiar with when it's fully sealed and not fully sealed, which can take a little bit of education. But nonetheless, even though it has less spread than monopolar or bipolar energy spread, it still has that, so you have to be careful nonetheless. I think the real danger to ultrasonic energy is that once you turn it off, once you start using it, it remains quite hot, as you can see here, compared to monopolar or bipolar instruments, which cool off fairly quickly. So you're trading less lateral spread and damage to a hot instrument that's always tempting to use it to retract something or to use it as a grasper, and it may still be hot and cause some energy. So that takes some, once again, some mastery of the technology to be able to use it safely. So in summary, energy devices are needed and quite critical in paraesophageal surgery. Lap pH is particularly at risk for injury-related major complications. Monopolar hook dissection is the most complex device to manage for safety. And even though many of us were raised on the hook cautery, it's quite useful in certain aspects. I think for this particular use, it's maybe not the best instrument, although I'd be happy to hear from the panel if anybody still uses the hook cautery for their mediastinal dissection. Most importantly, there's no perfectly safe energy source, and surgeons should be extremely well educated in the safe use of their particular choice. of an energy site. So all choices are effective or they wouldn't be on the market. And in the end, it's a surgeon's personal choice, but it's also their responsibility for safe and effective use of their chosen instrument. So thank you very much. Happy to bring this topic up for discussion.
Great. Thank you, Professor Swanstrom. That was a lovely talk. We have one question from the audience, the online audience. I suppose it's for all of us, really, maybe related to this talk and the previous one, but it's a question about pH and manometry. Who routinely among us perform pH manometry in bariatric patients who present with symptoms of reflux before we operate on them? So that's 2, 3, 4 out of 5. So quite a lot to do that. Perfect. That was just the one question that came in from the audience. So I think the answer is that most people would perform pH manometry on a patient presenting with reflux symptoms before offering them bariatric surgery.
I have a question. I don't know if I have a question on to Professor Svanstrom. You say that the monopolar hook or the monopolar scissors are maybe the less safe instrument to use, but some would argue that with this kind of energy, you may be able to do more perfect dissection. I mean, on really on the right planes, because when you use ultracision or when you use ligature, very often you just still planes together instead of going in between them. What would you respond to this?
I rather agree with that, and certainly I use monopolar scissors quite frequently and lymph node dissections and other very delicate fine lysis of adhesions, and I like it. I say it's not a worse source of energy, it's more complex because you have to rely on the people that clean the instruments not to damage the insulation. You have to rely on the nurse that puts the grounding pad on. You have to rely on the circulating nurse that sets the settings on the cautery machine. It's just more of a complex management thing. I think it's an extremely useful tool. I tend to stay away from it in the mediastinum. I like to use ultrasonic coagulation there, but bipolar sealing devices are very good as well. But they're thicker, they're not as precise of instruments, so there's an argument to be made about that as well.
Thank you.
Dr. Swanstrom?
Yes.
Contreras from Chile.
Hi.
Nice talk, interesting, very interesting, because had many things very useful for us. My question is, in the case of giant Hiatal hernia, is safer for you to use always bipolar energy, or the risk does not depend of the energy, depend of the surgeon, the expertise of the surgeon? This is my question.
Certainly. I think if you're used to using a bipolar sealer all the time for most everything you do, you're probably going to be best at that. And there would be no reason to use it for 80% of the case and then go into the mediastinum with a different instrument. And likewise for ultrasonic, it's got its own learning curve. I think, I use ultrasonic energy for 90% of my operations, I would say, of dividing. So I think you're right. It depends on what you're most familiar with and most comfortable with. Luckily, I'm sure most of us remember the old days when bipolar sealers first came out. They were quite broad and bulky and not very good for precise dissection, even though they were good at vessel sealing. now they're quite within Maryland.
Okay, thank you.
I have a question, since this is an international forum, and the adoption of robotics has been kind of moving forward a lot across the world. In some, platforms or in some countries, a lot of these vessel sealing devices are not available. And so monopolar is really the only option to use those platforms. Do you have any tips or for those that do have to use monopolar energy in the mediastinum? Because I know that it can be limited in terms of what devices people may have access to.
Certainly. I think kind of the usual things we're taught about monopolar energy, to use cutting current versus high settings of coagulation current is one, to use very short pulses of energy. So there's a lot of routine things that hopefully most surgeons are educated on that you can do to make it safer. And like I said, it's not a dangerous thing. It's just a more complex form of energy with more rules that have to be followed and potential risk for mistakes and errors. But I think that's, even Intuitive didn't have ultrasonic for 15 years. So all you had was a hook.
Yeah, and the ultrasonic device is still short and not articulate. I still use it, but it's not it's not there yet. Yeah.
Last question from me, because I assume you made some research, maybe even for this lecture. So my question would be if you are aware of any recent advancements or emerging technologies in energy-based surgical instruments. Are you aware of something coming that could make our lives easier?
Yeah, I think most of the advancements have been in the cautery machines themselves, so they're smarter. They help you control the current better and avoid applying too much energy and have cutoffs in safety. I've seen some emerging things that sense automatically the size of the vessel that you're trying to divide and can give you advice about whether it's safe to apply the energy or what kind of energy you should apply. So I think the electricity is still kind of the king in this, or heat and electricity. But luckily the machines are evolving and getting smarter and smarter. That kind of helps us make the right decisions.
Thank you.
Professor Swanstrom, thank you very much for your insights, your knowledge, your expertise, and answering the questions. Very much appreciated by ourselves and the rest of the panel.
Thank you.
So now we pass over to sunny Southern California, where it always is sunny. It's my great honor and pleasure from London to introduce Dr. Caitlin Houghton. She is the trailblazing robotic foregut surgeon in the Western and the Southwest of America. She proctors and mentors younger surgeons in links and robotic foregut surgery. She's going to speak to us today about why the robotic approach rules for the repair of giant hiatal hernias. So all the way to Southern California to Dr. Caitlin Houghton.
Well, thank you so much. It's such an honor to be here, and I'm excited to share this lecture with you all. So let me get my screen shared. Okay, so robotic rules for giant paraesophageal hernia. I really do think we've talked a lot about today already how we are operating in a tight space in the mediastinum with so many critical structures. And we really have to, in order to do these surgeries and have good outcomes, we really need all the tools we can to keep the control and be precise and really have great dissection. So with that, I wanted to talk a little bit about the historical perspective of treating these giant paraesophageal hernias, because it has changed over time. And there's reasons that go behind that. So incarcerated paraesophageal hernia in 1973 by Dr. Hill. Basically, there was a paper that said paraesophageal hernia, all comers, it's a surgical emergency. Everyone needs surgery who has a paraesophageal hernia. That was challenged in the 2000s, where there was this paper that kind of showed the annual probability of emergent repair was about 1%, as we heard before. And that really the risk of having an incarceration or having a strangulation was a little bit lower than that. And so it was about 0.5. So watchful waiting then became the norm. So for everyone, symptomatic, non-symptomatic, everyone was under the impression now that maybe we should be watching these patients and kind of waiting for that strangulation or that emergent type of situation. SAGE's guidelines in 2013 challenged that again. They quoted a 14% per year chance of an asymptomatic hernia becoming symptomatic. So you have a high chance per year of an asymptomatic large paraesophageal hernia becoming symptomatic, and 2% per year risk of symptoms severe enough to require a surgical intervention. So then they challenge to say, well, elective repair of asymptomatic hernias should be on a case-by-case basis. However, symptomatic patients have a high risk of strangulation and ischemia events. So all symptomatic patients need an operation. Now, also the word of symptomatic, what does that mean? Is it just ischemia? Is it obstruction? Is it dysphagia? I think we have a little bit of work to do on that, but I think patients that have especially dysphagia, early satiety, decrease in their meals, nausea, vomiting, those are all patients that should possibly require a repair. If we look at the current perspectives in the field, there are some clinical prediction models, again, for giant paraesophageal hernias. And this one really looks at laparoscopic repair has excellent perioperative outcomes when performed electively. We don't want to get to that urgent repair because urgent repair increases mortality to about 8.8%. So we don't want to wait for our patients to need an urgent repair when our minimally invasive techniques are really good at getting patients through it with very low risk in an elective scenario. And there was one independent predictor of needing an urgent repair, and that was an intrathoracic stomach of greater than 75%, whether the patient was symptomatic or not. This leads us to now thinking, okay, well, if there's a giant paraesophageal hernia, which are kind of the more complex hernias to fix, we should be fixing them electively, but often these patients are in the older generation. They might be 80s or 90s because we've had so much of that watchful waiting. So is the surgery in the modern era safe for asymptomatic patients? And this paper by Dr. Damani looked at this to look at patients age 65 or greater to see if it's safe. And in this paper, the mortality remained below 0.5% until the age of 80, when it started to creep up a little bit. And they really attributed this decrease in mortality to the MIS advancements such as robotic surgery and surgeon specialization in high volume centers. And the risk of watchful waiting was approximately 5 to 17%. So the recommendation is, yes, it is safe in the modern era to take these patients to surgery, whether they're symptomatic or not. Definitely if they're symptomatic, and on a case-by-case basis if they're asymptomatic, but knowing that we don't want to get to that emergent state. So even in asymptomatic hernias can be fixed with low risk until about the age of 80, where we really have to have a very specific conversation with the patients. So that gets me to the robotic paraesophageal hernia repair. Why are we going to do this robotically? We know that this is a very delicate surgeon. The odds are against us as far as recurrence. We need to do the best thing possible at the index surgery for these patients. That includes reduction of the hernia, high esophageal mobilization and crural closure. we also need to manage that sac as efficiently as possible. I'm going to focus on sac reduction first, then go on to a little bit of the high dissection and mitigating radial tension. So the sac reduction, I love the robotic platform because of the visualization and the autonomy that it gives us. In this case, I can be my own retraction, my own camera work, and I can follow natural planes, which is going to allow me to do this procedure with the precision that it needs. I find the best way of getting beyond the sac so that we can pull down the sac without touching the stomach at all. I like this no-touch technique of the stomach. We need to get beyond the sac, so I need to open the peritoneal covering on the crus to reliably get beyond the hernia sac. And if we can grab that hernia sac right away and push that muscle, you can see there's some pleura probably creeping in there, some peritoneum covering. And now we can spread this open. I do like the monopolar vessel sealer robotic instrument for this, because we can not only use it as an energy device, but it's a really good blunt dissector. I like how it opens, both jaws open widely to get into those nice planes that we're looking for. Especially in this patient with a lot of fat on the sac, we really need to be careful about digging up too high in the fat that could be right above, like on the pericardium. So we're just trying to detach the hernia sac from the crus at first. This will allow us, you'll see, then I'll pull down a little bit of the stomach, just what's easy. I'm not trying to reduce it, but I do want to get down that the left crus and be able to see that. So we're going to turn our instrument and go right down the left crus, giving us just the control that we need. Once we have this sac kind of detached from the hiatus, you can see I want to get one more bite there, really get it detached from the hiatus. Now, if we hold that sac, this is where it's really difficult. We often have to get way over around that crus, and we can use our wristed instruments. I can see the pleura and pushing the pleura off the sac, or pushing the pleura and the mediastinal structures off the sac. This often is an easier part of the procedure. I find that the esophageal mobilization is more difficult than actually reducing the sac. So this sac came down very easily. What if you have a sac that's a little bit more difficult? The robot can help in this scenario too. So just showing you that this is another very large paraesophageal hernia, large hernia defect. I'm going to start the same way. You can want to watch the gastric pedicle there, the left gastric pedicle. But we're going to start the same way, using detaching the hernia sac. We're detaching, finding that pleural plane, and easily getting into that plane. But you'll see here, I'm starting to have difficulty getting this down. I can't see it. It's not coming down. I'm trying to pull on it and I just can't see it. But if you can turn the camera 30° up, in this case, and drive that camera up into the mediastinum, now I can see exactly where those attachments are to the pericardium. And now I can get that sac down in completion. So I think the robot does help a lot in getting the hernia sac down. Now, that's only the beginning, because once you've got that hernia sac and the hernia reduced, now it's really about mitigating the tension. We need to mitigate radial and axial tension to decrease the risk of recurrence and decrease the risk that this comes back. And often when we get the sac down, our G junction is still in the mediastinum, high above the diaphragm. It's been thought that extensive mediastinal dissection and getting the length of the esophagus down into the abdomen is one of the critical things that we need to do. The gold standard, I guess, one of the long-standing things we could do is a collis gastroplasty, but that is makes it a little bit more challenging a procedure. It may not be in every surgeon's armamentarium, although it should if you're doing a lot of these procedures. But there is suggestion that a high esophageal mobilization up to 10 to 15 centimeters can eliminate the need for a lengthening procedure. I think in my practice, I need to do a collis about 3% of the time. But this high dissection does help eliminate collis for probably 5% that may have needed it otherwise. And what does that look like, and how does the robot help us with this high mediastinal dissection? Well, again, I want to be able to visualize every structure in the mediastinum as I'm doing this dissection. You'll see I'm putting the penrose up in the mediastinum. Our G junction is about where this penrose is, which is high in the, still high in the mediastinum, even though my hernia is reduced already. Sac is down, but this penrose in the chest is gonna be around the G junction, and I'll know that I've got pretty good length once that penrose is beyond the diaphragm. But now I can see the pleura, I can see the vagus nerves, I can use my vessel sealer with very precise control and visualization around these critical structures to mobilize the esophagus and dissect the tissue so that I can get high mobilization. Now here again, I'm kind of looking really high in my visual plane. And although I can see pretty well, I can't see as well as I want to. So you'll see in a minute, when I'm looking high in my visual plane, that's a cue to me to turn my camera 30-degree up again. So I can really see the bottom of the esophagus to know where that is, so I can preserve it appropriately during this case. So again, retracting the esophagus, I can see pretty well, but in a minute, you'll see that I have a little bit of trouble, and I want to see just a little better visualization. We're already pretty high. I need to get a little higher. There's where I turn the camera. Now I really can see this junction between where the posterior esophagus is, where the aorta, and where all those little vessels are that I need to divide. I can divide these cleanly without blood stain, and without a lot of blood in the mediastinum. And that really keeps this very, very, very controlled. Let's get through. Oops. So I was going to show you the end product of that, but I skipped ahead on accident. But just with that control, you can really then get the length that you need to have the esophagus in the abdomen where it needs to be. The other thing we need to do is mitigate the radial tension. And there's been some papers that kind of show this is more difficult, I would say, in these large hernias. But there is a paper here by Bradley and Louie that shows kind of what is going on with the radial tension and how can we reduce it. There are tension reducing maneuvers. This paper used a tensometer in the OR to actually measure what that tension was, and it had a goal reduction in that crural pillar tension as you bring it together. So it was a really interesting paper. Did show that our tension reducing techniques such as a left pleurotomy can decrease our the rate or the tension by about 46%. A right relaxing incision decreases the tension by about 46%, and if you combine them, it's about 56%. You can also, there we go. You can also look at the shape of your hiatus and kind of predict whether you're going to need a tension reducing maneuver. If it's a slit, only 32% of patients didn't meet the required tension measurement that they were looking for. If it was a teardrop shape, about 50%. This D-shaped is about 63%. And they found in this paper that 100% of patients with an oval hiatus at the end of dissection needed a tension reducing maneuver. I don't always do these tension reducing maneuvers, but this paper does kind of suggest that maybe we need to look at that a little bit more. Unfortunately, we don't have a tensometer in the OR with us most of the time, or all of the time. So what have I done in the past when I don't use these maneuvers? I think you can use the left pleurotomy would be my go-to if I needed it, but you can approach the crural repair a little bit differently as well. So this is using a V-lock suture. I like to use a running V-lock suture in the posterior plane. Most of my small hiatal hernias, I just run right up the posterior plane. And the robot is great for the suturing and kind of getting these crural pillars together. You can see it's coming together pretty well, but now as I'm getting up, it's going to be hard to get that together in the posterior plane. So what I can do is run kind of the diaphragm together from the side and turn this and do kind of start going laterally to close this defect down a little bit more. You do want to make sure that your Penrose is kind of adjusting the esophagus in its normal position, so you don't lateralize it too much. So here we're going to just close down that hiatus. I'm going to close that down. Sometimes I do need to put an additional Ethibond suture at the other side if it's not closed down completely. And then 1 second, I have one more video. Sorry, I'm going to have to go back. And then the other thing we did talk about is just mesh. And most people would put this in a posterior position or reverse C. And I do like, recently, I saw this by Christy Dunst, actually showed this at Sages in Cleveland. So this is a very new addition to my practice. But I really do like this buttressing technique. And if you think about mesh as trying to take the tension off your repair, so that if the crural pillars are trying to separate, the tension is transferred to the mesh. I do kind of like a buttress technique where we're using the mesh almost as you would pledgets in an open surgery, but also have the mesh plane. So I'm using a V-lock. This is very difficult lap. I've done this lap and robotic. The robotic platform is really a lot nicer for that control of where you're placing these stitches and being able to get this mesh controlled really nicely. I'm going to skip ahead a little bit just to show you what this looks like at the end. So we're continuing up, closing the crural pillar planes as we're putting this mesh on as a buttressing technique. And you'll see as we do this and run up the crural closure, keeping these nice and spaced apart. The end product, yep, kind of buttressing these together. In the end, it looks something like this. So instead of just laying the mesh there and hoping that it has enough connection to the pillars, maybe this has more connection, is actually going to build the collagen where you want it, and maybe takes that tension off as if the crural pillars are going to separate. So those are my, in summary, a giant paraesophageal hernia repair using robotics provides high definition visualization and wrist manipulation, which aids in the identification of the native planes and preservation of critical structures, even with high esophageal mobilization. Suturing is facilitated to help close even the difficult crura, and surgeon control is optimized. I have all the autonomy that I need to really control the case optimally, even in the most difficult scenarios. So thank you.
Dr. Harton, thank you so much. What a fabulous talk. And the videos always really bring it to life for us. And I'm sure the patients are very grateful. I'm sure your own cervical and thoracic spine is very grateful when you can sit to do the operation rather than stand for hours, stretching over sometimes very large patients. So benefits for the surgeons, which in turn benefits the patients. So we'll open it to the panel for questions. Who has a question for Dr. Harton?
Okay. Thank you, Dr. Jardine. I completely agree with your talk, and congratulations for this. We did and we do in my institution also robots repair the higher hernia and reflux and bariatric surgery. I use the Da Vinci robot too, and your topics is similar our experience. But I have one question for you. The classical case is the patient with about 80 years old, completely asymptomatic, no reflux, no pain, no problem with the digestive symptoms, and she do in the check CT scan, and surprise appears higher hernia grade 3 or 4. Repeat, completely asymptomatic. What do you do, doctor, in this case?
Yeah, I think those are the most challenging, right? Because they have risk of their entire stomach and their chest, but if they are truly asymptomatic and you tease out in questions, because a lot of times patients don't think that their symptoms are attributed to the hiatal hernia. So sometimes you have to ask questions like, are you having dysphagia? Are you changing your diet to softer foods and things like that? But in this case, if they truly are asymptomatic, I think you look at their comorbidities and weigh the risk. If they're 80, completely asymptomatic, I probably can't make them a lot better than that, but I know that they're more likely to have become an emergent repair. So I have a very honest conversation. I wouldn't just have one conversation and let them leave. I would bring them back and have them talk to me again, 6 months to a year, maybe 6 to 9 months, just to see, check in, are there symptoms? Because you want to catch them before they come urgent. So I may do some surveillance on those patients, active surveillance, instead of operating. But if they are symptomatic and they've had some dysphagia or retching or anything like that, I often will recommend a surgery.
Thank you.
Caitlin, can I ask you a question as well? Great presentation.
Absolutely.
I think comment
Thanks.
first, I absolutely agree. Watch and wait is not the way to go with those old patients. Usually, they become symptomatic and you run up into serious problems. My oldest patient was a World War II veteran at the age of 97, left the hospital third day after the operation, happy man. So he was very vital. This is not the usual case. Nevertheless, what I really would suggest, because you've really have an excellent way of addressing this problem, but you know, the V shape or the oval or the slit shape, that's more like a fashion magazine type of description. Let's just stick to the hiatal surface area, because that's a scientific way of approaching this. And if we all kind of pick it up and talk to each other, say, well, this patient had a hiatal surface of 9.8 square centimeters, and we know what we're talking about. So this is something I would like to suggest to all of you out there. Pick it up, the pointer paper. It's not easy. It's not difficult to do, and then we know what we're talking about. What do you think
I really
about,
like that, by the way.
Yeah.
The hiatal surface area, because I think what we do lack is sometimes are we talking about the same thing? And so I really do think that we need this commonality of language in order to communicate across the specialties. So I really like that idea, and I will start using it.
And do you think there's something like a short esophagus that because you know, it's always in the literature, people talk about it. I have to do colors all the time because I encounter all these short esophages. I never do that. I hardly, no, actually in 500 plus operations, I had like 2 colors procedures, but that's it. All the others, will come down. You just have to dissect all the way up.
Yeah. So I think that it's a relative term. I think if on a video esophagram you see that there's shortening, you've got to be prepared to do a very high dissection or collis gastroplasty. I tell this story because in the first 5 years of my practice, I did 0 collis, but I also probably wasn't comfortable with collis, so didn't do it. And there were probably 1 or 2 patients or 3, you know, in that 5-year period where maybe I had 1.5 centimeters of length, and I'm like, yeah, but compared to the huge paraesophageal hernia, that should be okay. But I've been burned. And those patients have come back with symptomatic hiatal hernias, and I have my videos, and I can go back and see, well, maybe we compromised a little. So I now do high mobilization. I take off the sac. I do an endoscopy to make sure that I know where the GE junction is. And if it truly is not there, will do a collis, but I've probably done, like I said, it's probably about 3%, but I see a high volume of these patients. So I've probably done 2 or 3 per year, with doing about 50 per year.
I have a question.
Exactly my question, because, you know, with this amazing high mediastinal dissection, I would have expected this percentage to be a lot lower than 3% and closer to 0. But you have already explained the reasons, and congrats for a great lecture.
Thank you.
So I'll just start wrapping this up. Kaylin, I really enjoyed your lecture as well. Obviously, I'm a huge robotics proponent and I do all of my foregut robotically. And I think especially when you're doing redos, as most of us end up doing, there's a lot of value for that. And I think Collis also comes into play when we talk about redo cases. And so I'll kind of wrap up on that note. I think we had a lot of very nice talks today. We touched on a lot of points in a very short amount of time on a very complex and difficult problem we all face. And so I thank all the speakers, moderators, and we will turn it back to Dr. Ortiz to close out the webinar.
This has been an IBC Oxford University Hot Topics and Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics and Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars as the 5th IBC University of Oxford World Congress is taking place 17th through the 19th of 2024 at the University of Oxford, United Kingdom. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
Day after day, you answer the call, giving your all for every patient. Driven by the fact that every surgery but at times, it can feel like your choices are limited. That changes today. We believe empowering you with more choice in the technology you use, the program you create, and in the partnership you build will drive a new era in surgery. As the first company with solutions across open, lab, robotic, and digital, giving you more choice is central to our mission. More flexibility, more portability, more efficiency, more open communication, and surgeon-designed ergonomics. It's about supporting you through planning to help you build a sustainable, optimized surgical program. It's about advanced evidence-based training and continuous improvement. It's about bringing the benefits of minimally invasive robotic surgery to more patients in your community. Through our continued partnership to build your vision, together, we can make a world of difference. Now, you have a choice.